Thank you, and welcome everybody to day two. So it is my honor to welcome to the stage close friend and colleague, Dr. Arnoldo Riquelme. Dr. Riquelme is professor and member of the Department of Gastroenterology at Pontificia Universidad Católica de Chile. And Dr. Riquelme is a very established clinical researcher, and areas of expertise include H. pylori infection and development of gastric premalignant lesions. And he's also the former president of the Chilean Society of Gastroenterology and the Pan American GI Organization. So welcome, Dr. Riquelme, who will be speaking on the ECHOS cohort.
Thank you so much, Shailja, for your kind presentation, and Rob. Good morning, everyone. So I think what I'm going to do now is to present our experience about the ECHOS Cohort Study, the global perspective about gastric atrophy and intestinal metaplasia in Latin America. As an introduction, gastric cancer is prevalent in Asian countries like Korea and Japan. But what is different, the approach is in Korea and Japan, they have universal screening based on EGD, and they are not taking biopsies. So what happened in Latin America, like Chile, Colombia, Peru, Ecuador, and Costa Rica, Latin American countries show higher mortality related to higher proportion of patients diagnosed in advanced stages because we don't have this access to EGD. And what we are going to do is to explore endoscopic classification for gastric atrophy, intestinal metaplasia, and the Chilean experience based on endoscopic cohort, which is the ECHOS cohort study. We use Sydney protocol biopsies for risk stratification, and the strategies from Chile and America are proposed based on these findings. So what we have here is the risk of gastric cancer in terms of the incidence. And the incidence, as you can see, is very high in the Pacific coast. So it includes some countries in Central America, like Guatemala, Nicaragua, Honduras, Costa Rica with a high incidence of gastric cancer. And then would you move down to Colombia, Peru, Ecuador, and Chile, and we have similar incidence. It's intermediate compared to Asian countries, is around 12 to 14 cases every 100,000 inhabitants. So here is the GloboCan actualized in 2022, and the ASR incidence is on top is Peru with 14.3, and then it's Chile. And you can see how you move below 10 from IT, and then you have other countries that are in the Atlantic coast, which are not in high incidence, like Uruguay, like Argentina, and Brazil. So moving forward to the Chilean experience, what we are doing now is to take the information provided by the Correa's cascade, starting with normal mucosa, and then chronic gastritis, superficial, and then you have atrophy, intestinal metaplasia, dysplasia, and gastric cancer, mainly related to adenocarcinoma. This is the incidence of Chile is different. We have 14 every 100,000 inhabitants, but Chile is also very heterogeneous. So in up north, near to Peru, the incidence is below 10. But then you have Santiago, which is intermediate for us, and we have other regions in the south of Chile, and we have 45 per 100,000 inhabitants. So it's different, and also the strategy should be different even if you are talking about one country. And I think most of your countries could have the same situation. The ECHOS cohort study is based on upper endoscopies. We started in 2015, so the longest follow-up is nearly 10 years now. but our median is around 4 years. And that's important because we are recruiting prospectively patients, and we started in that time, but we are recruiting every day patients, new patients, and we start again with the cohort. So it's very dynamic, this process, and during these years we have several collaborations with some people, like for example Rob and Huang, about spatial transcriptomics. We are going to work in that in the future with UCSD, with low-pass sequencing, and we are collaborating with Baylor College with the microbiome analysis. So our studies are based in blood samples, in paraffin blocks, and the information provided by the endoscopies and the follow-up in terms to the main goal is to detect what are the components in terms of the genomic and microbiome analysis related to progressors and regressors to different stages of Olga and Olguin stagings. So genetic variation based on gene polymorphisms, altered expression of non-coding RNAs. And we are working in these long-coding RNAs mainly with Alejandro Corvalán. He was here in the summit, in the last summit in 2022. And microbiome alterations based on dysbiosis that we detected. For example, we detected a high, the relative abundance of Streptococcus is high, and also Limolactobacillus in our cohort, and is lower the presence of Prevotella and Veillonella. So if you take this information, then you can have something like a fingerprint of microbiome and genomic profiles that are related to progressors or regressors. We started before the ECHOS Cohort Study with a PREVECAM project. It was a fantastic journey with Alejandro Corvalán. He's our basic science leader. I'm doing endoscopies and clinical work and the data manager. But also we work together with the pathologists. I think it's important to work in a very collaborated environment, because you are, the pathology should be your friend, not your enemy, when you are talking about new classification. Sometimes it's more work for them, and sometimes they need to be very systematic in the reports, or to do additional analysis when you are working, because we use only Olga for clinical information, but we have additional analysis for Olguin, and this was very useful to compare the information. You can see here in this slide that at least in Chile, between 18 to 29 years old, there is only non-atrophic gastritis. And then when you move over 30 years, then appears the first cases of atrophy, and then at the 40 and over that, you have the intestinal metaplasia, and then the increased prevalence of gastric cancer. So the hazard ratio for gastric cancer in this cohort was 3 when you are 50 years old or over. So it's important to analyze what is the time length for the development of atrophy and gastric intestinal metaplasia, and also gastric cancer. What happened in Chile? The first movement was based on the ACHED, is the endoscopic. It's like ASCE for you, is the endoscopic gastrointestinal group, which is mainly focused on endoscopies and colonoscopies. They developed this protocol, and it was based on gastric biopsies, Sydney protocol biopsies, Olga staging, and over 40 years old. And this is relevant because the follow-up that was proposed at that time was to do, in 2014, the idea was to do annually for Olga 3 and 4. So nowadays looks very strict, more than it is part of the guidelines, but this was 10 years ago. And the idea now is to move to every 2 years. So this is it's not yet published, so it's the update version of this protocol is going to be every 2 years. And what happened with the ECHOS Cohort Study, because of that, because we followed the ACHET protocol, we use the same strict follow-up annually for the ECHOS Cohort Study. So we have 140 patients with a strict follow-up in our cohort, and the biopsies are annually. And then the next stage is HOPE. HOPE is a project related to secondary and primary prevention of gastric cancer. The primary prevention is based on UBT, test and treat, below 40 years old, and the main focus is between 30 to 39. And for secondary prevention is over 40 years old, following the same ACHET protocol. So we use serum biomarkers, the gastro panel, using gastrin 17, pepsinogen 1 and 2, and H. pylori serology. And we add demographic data to develop a predictive rule to identify which are the patients at higher risk to do endoscopies in this group at higher risk. And when you perform endoscopies, the EGD is always with the gastric biopsies following the Sydney protocol. About atrophy, we follow the Kimura Takemoto classification. We use it, is based on if you have a pattern is close, then the risk is lower because you have only atrophy in the antrum. And if the atrophy is going up through the corpus, then you have the open pattern, which is in contact with the esophago and gastric junction, and then you could have O1, O2, or O3. This is relevant because we don't need biopsies to apply this classification, and what is important for us is in Molina City, which is part of the first stage of the HOPE project, we started doing this Kimura Takemoto in correlation with gastric biopsies. And you can see here the ROC curve for Kimura Takemoto and Olga prediction is 0.85. And what is important is the patient at higher risk to have Olga different than 0 or 1 is if you have C3, O1, O2, O3. On the other hand, if you have a GIM is a endoscopic classification for gastrointestinal metaplasia developed in Portugal, and a GIM is also correlated with all GIM. So we take biopsies and we perform in all patients a GIM, and you can see here that the ROC curve is 0.83. What is more relevant is when you add all together the Olga and Olgim staging and Kimura Takemoto and a GIM classification, if you have a Kimura Takemoto with low risk, so it's C0, 1, or 2, and you have a GIM 0 or 1, the negative predictive value is 99%. So you can avoid nearly 60 to 70% of the biopsies, and this is going to be our next stage because we need to calibrate this and we need to train all the endoscopists to avoid unnecessary biopsies. And now about the the ECHOS Cohort Study. Our results are published in GAT. And you can see here that we started with 7,000, nearly 8,000 biopsies, but only with a strict follow-up, we have nearly 700. And the proportion of Olga 0 or 1 is 77%, Olga 2 is 15%, and Olga 3 and 4 is 8%. So in Molina City, which is one of the highest risks in terms of incidence of gastric cancer, even there, the Olga 3 and 4 is 12%. So it's not, we need to identify how we can get to this 1 out of 10 patients or subjects that are part of a community over 40 years old. And what is relevant is when we performed the surveillance and the endoscopic with the strict follow-up, we detected 7 adenocarcinoma, 6 at early stage, and high-grade dysplasia 4. And we have another 11 low-grade dysplasia that disappeared. So they are not, they appears, and then with the endoscopy, we never found progression of them. Here are the cases. Most of them resected by ESD, but some of them requires a gastrectomy. All of them are alive now. So the 91% of the malignancies at our early stage, and I think we can prove in that way that we could have very good numbers if we follow this protocol. About Olga and Olgim, so Olga staging is the first communication was from Rouge, demonstrating that Olga 3 and 4 are at the highest risk. And then the group from Singapore, the GCEP cohort, demonstrate that Olgim is a very good way to detect patients at higher risk, and it was the same for us. So the Olga 3 and 4 are at higher risk. You have Olga 2 with the intermediate risk and no risk for 0. If we perform different analysis, new analysis in our cohort after this paper, and Olga 0 and 1 are at low risk. The main focus for us now is Olga 2 with a new follow-up, and Olga 3 and 4, which is already know that is the highest risk for gastric cancer development. And this is not fixed; it's very dynamic, as you can see here in the Sankey graph. That you have many patients starting with high risk, mainly with HP positive and high scores of inflammation, and nearly 30 to 40% in the long-term follow-up goes down. So the Olga is not fixed forever. If you are Olga 3 and 4, but you have HP, you need to restage the patient after some years. We have no clear idea about how many years you need to wait to reclassify and re-stratify the risk of these patients. And you can see on the other hand that Olgim is more stable, it's still dynamic, but it's more stable in terms of the metaplasia compared to the atrophy. So Olga and Olgim scales are good to stratify risk progression of high-grade dysplasia and gastric cancer in Latin America. We are focusing endoscopy and how we can reduce the burden of endoscopy. We don't have these 5 million endoscopies that is already performing in Japan or Korea, but we need to be wise and how we can use the efforts that we already have in our continent. What is the new idea of the new ACHET protocol, which is already in a process of release, is to move from every year the follow-up to 2 years follow-up in Olga and Olgim 3 and 4. And the whole project is 30 to 39 years old, test and treat based on UET. We are using dual therapy, and we will have soon information related to that. We also use For HP eradication, we include all the patients in our HP Latam Reg, which is the same record, the red cap record that used the European group. And from 40 to 75 years old, we use this serology combination. And what is the new proposal for the ACHET protocol is to do endoscopies, EGD, every 2 years for Olga and Olgim 3 and 4, for Olga 2 every 4 years, and no follow-up in terms of the Olga and Olgim if they are 0 or 1. In summary, this is a paper that we published with several co-authors. Some of them are here, like Constanza Camargo. It was a recommendation for gastric cancer prevention and control in the Americas, and I used bold letters to see what are tackled in this presentation. I think we are covering many of these points, and I think we need to move forward to do something that is going to be a high impact in our continent. Thank you so much. So, 3 seconds.
Perfect. Perfect.